hope the experience has been a good one. You've heard about the feedback. We do want the evaluation forms completing. It's only by hearing from you what you thought of it that we can actually think about what we do next. Now, let's make a start on this session. Before lunch, we heard Lisa Pickering talk to us about the management of metastatic prostate cancer. And to try and amplify that message and look at it in real clinical settings, we've got a double act. Rob Jones is a medical oncologist. He's an Englishman who works in Glasgow. We've got Rhona, who is a clinical oncologist who's a Scot who works in Newcastle. So between the two of them, I suspect we're going to have fun and games. I'm going to leave it to you as to how you want to run it, but I'm sure you'll be looking for interaction from the audience. Is that right?
Indeed. So thank you very much for the introduction. So yes, as it's been said, I'm Rob Jones. I'm a medical oncologist in Glasgow. I think there's another important distinction between us as well. And first is that I'm what's known as a clinical academic, and I spend a lot of my time in research. And so I come to this with a very biased patient population. But Rhona is a real live oncologist.
I see lots of patients and do lots of work.
I'll
give you the live perspective. So.
And this is beautiful scene of beautiful Scotland, pure blue skies, empty beaches. Always be very suspicious as to what the temperature might actually be. So, how do I actually advance the slides? Okay, so we're going to do a lot of interactive voting through this session. I've told you all know how to do the interactive voting buttons. It's the first time I've done one of these where it actually gives the names of all the individuals in the audience and how they're voting, so great interest. So first question actually, we thought about the first question might be testing you on your knowledge of steroid biosynthetic pathways, just the fact that we took in everything before lunch. We passed on that. So first question, men with metastatic prostate cancer should be considered for chemotherapy. Well, the question is when should they be considered for chemotherapy? Option A is soon after they become castrate refractory. So soon after the PSA starts going up after castration therapy. B, only after they become refractory to all available hormone therapies, i.e. hormone refractory. Or C, once they're hormone refractory and symptomatic. Or D, once they are hormone refractory with uncontrollable symptoms, that is, painkillers and radiotherapy are no longer working. So, if you'd like to vote now, so really the important number from our point of view is the number one in the bottom, because that tells us how many have left by the end. Right, so let's see the results of this. Okay, so majority are going for once they are hormone refractory and symptomatic. That's interesting. I'm glad that not many people voted for D, but I still think that's the view that quite a lot of oncologists still take with chemotherapy, actually. And there seems to be the remainder roughly split between A and B. Now, we're going to spend the rest of the session, I think one of the things that will come out most. I think this is still one of the greatest uncertainties in particularly chemotherapy for castrate refractory prostate cancer. So the next question, where would you most like to be right now? A, right where you are. Now you'll see that B, nearer the front, you'll see that I didn't actually know the layout here. When I set this question, Scott's nearer the front, he's also nearer the door. But you know what I mean, okay? Or D in the bar. Would you like to vote now, please?
You know what it's going to be.
More people have voted this time. Who is it? There's one person who didn't vote last time. Who is it? Should we go home right now? Okay, so our task is clear. You all want to be out of here. So we're going to go into some case presentations. The first case is a case of mine. It is a 67 man of 67 years of diagnosis. Now, I want to put a little disclaimer in here, really to echo something that Lisa said before lunch, and that is that PSA is very much only a part of the picture in how we assess these patients. But nonetheless, it's a very nice way of pictorially displaying the way patients change over time. So you're going to see a lot of PSA data. That is not to imply that it is the most important factor in decision making in this disease. So I just want to put that disclaimer in. So here we go. So this is the story so far. This man was initially presented with high-risk early prostate cancer and was initially treated with chemical castration therapy, Castrate, which is Zoladex. And then after about a year, he had radiotherapy. Of course, we now know that that probably should be the standard of care. We didn't know that actually this time. The radiotherapy of local advanced disease in combination with hormones is probably optimal treatment. And then after about 2.5 years, his PSA starts to climb. And at this point, bicalutamide is added in. He doesn't have any known metastatic disease at this point. And he gets maybe a slight dip in his PSA after the addition of bicalutamide. But about a year later, the PSA is going up again. Bicalutamide is withdrawn. We all know that occasionally you see the PSA going down after withdrawal of bicalutamide. We did not see that in this case. And at this point, the PSA now starts to really go skyrocketing up. We've got a very rapid doubling time. And it's at this point when my colleagues squeal for the academic medical oncologist. And so this is when he was referred to me. At this point, by the way, he also was diagnosed with nodal metastases, although this was asymptomatic and a bone scan was clear. So he's got para-aortic nodes and a rapidly rising PSA. So the next question is, what are you going to do next for this man? So he's asymptomatic, metastatic, castrate refractory, bicalutamide refractory. The options are docetaxel prednisolone, mitoxantrone prednisolone, third-line hormone therapy, whatever that may be. Remember, we don't have access to all these fancy things like Abiraterone and MDB-3100 yet. Or you're going to sit tight and wait and watch, seeing as he's asymptomatic. Would you like to vote now, please? Still that waiver from the bar. Okay, right, so that's interesting. Despite that most of you said you would defer chemotherapy until you were symptomatic, actually 2/3 of you want to give him chemotherapy now. And I suspect that's because you're quite scared by the trajectory of his PSA. So this is a man who, in fear, is running into trouble fairly soon, would you say, Dr. Menemem?
That may be the
So
case.
what would you do in this situation, Dr. Menemem?
Well, I think there are three things to think about here. I think this man has probably had what you would expect to be the median response to hormone therapy. He's got locally advanced disease, it's poorly differentiated, and it's certainly becoming less sensitive to hormone treatment, and I think we can certainly say that. The rising PSA reflects an increase in the pace of the disease. I think that's as much as you can say about that. But the patient does remain asymptomatic. He's got bulky radiological disease, but he doesn't have any symptoms. So this is a palliative situation, and we know that. And I think what we have to think about is further hormone manipulation, and there's certainly rationale for that. Or do we think about chemotherapy, and there's certainly evidence for that. So that's what I would say at this point.
Would you do a bone scan?
I shall ask Dr. Jones.
So, in fact, he was restaged at this point, and he still only had nodal metastases. They were enlarging.
Can I ask a quick question? Sorry.
Yes?
When would you have liked him to be referred to you?
I'm happy. I hesitate to say this. I'm happy to see anyone anytime. I spent lunch complaining to my nursing colleague from Ayrshire there that I can't manage my clinical workload effectively at the moment. But I think that's I don't know actually. There aren't very many medical oncologists in the UK treating prostate cancer. I'm very much of the opinion that the sooner an oncologist, I don't think it matters whether you're a medical oncologist or a clinical oncologist, but I think the sooner an oncologist sees them, the better, because if we haven't got anything to do at that time, we're not going to waste a lot of time with them. But I think this may be something that comes out during the course of the session, actually, is that actually I think maybe an earlier referral may be more important in the future. So, do you want to just talk to these data? I think Lisa's already effectively discussed these data.
Yes, I think she has, but this is a curve that you'll obviously all recognise, and it's the TAX327 study. It was the two different regimens of docetaxel, the standard 3-weekly, the weekly against the gold standard at that time, which was Mitoxantrone, and we can see the survival benefit there.
And I think it's worth pointing out that approximately 50% of the patients in this trial had either no symptoms or minimal symptoms at the time of initiation of chemotherapy. So it is quite clear that asymptomatic patients also get the survival advantage. It's certainly not confined to symptomatic patients. And I think you could make the point that this patient is heading for chemotherapy at some point, whatever we do next, why not go straight for it now? You know, it's merely putting it off rather than putting it off forever.
Can I just ask you something? Would you ask the patient what he wants?
Oh, absolutely. Clearly, we would discuss this. Yeah, clearly. And interestingly, this patient, his own views on chemotherapy changed through the course of his disease in an interesting way, which will come apparent. The other thing to point about Mitoxantrone, which was mentioned, actually remember that Mitoxantrone is not licensed in the UK for the treatment of prostate cancer. It never has been. And that its only proven advantage in phase 3 trials is to improve symptoms, and that those trials did not include asymptomatic patients. So I think it's very hard to make a case for giving Mitoxantrone to an asymptomatic patient. So, in fact, this patient received third-line hormone therapy. Now, in fact, part of the reason for this was that at the time docetaxel was not available, and I suspect if he was presenting today, I would have given him chemotherapy. But he was given stilbestrol, a drug for which there's very little evidence, but widely used in the UK. And as you can see, his PSA came down a little bit and sort of bumbled around for a while. And so, you know, these are months along the bottom. So I mean, you could argue that he's probably got at least a year of PSA control out of this. But then, after, so we're now sort of talking about 7.5 years into his treatment, hormone treatment, he's now, again, PSA is going up really quite rapidly again. Although he remains asymptomatic, repeat scanning shows, again, no bone metastases, but progression of his lymph node disease. So I asked the same question again, what would you do now? The patient has done very nice, he's done nearly 8 years on hormone therapy, when presented with nasty high-risk disease. Are you going to A, continue with the current treatment, B, are you going to switch to the chemotherapy now, or are you going to stop the stilbestrol and wait and watch, so subtly different from A and C, or are you going to try and find a fourth-line hormone therapy for this patient, whatever that may be? I would use dexamethasone as a fourth-line hormone therapy in this situation. Okay, so you're being quite consistent here, but it's interesting that that's a bit of attrition on the chemotherapy there, presumably because you're all quite impressed by the way this man's benefiting from hormone therapy. I think none of us would doubt if you hadn't had any treatment, you would have certainly been in trouble, almost certainly dead by this point. So, but we started chemotherapy at this point. And in fact, it was in a randomized controlled trial. It was actually the GVAX trial comparing a vaccine with chemotherapy, and he drew the control arm of the chemotherapy. And you see, well, I've noticed the y-axis scaling has changed quite considerably here, but his PSA stopped going up. In fact, it came down a bit with chemotherapy, and he had quite a prolonged biochemical response to chemotherapy. And that's pretty good. He got 10 months out of chemotherapy. That's pretty good for chemotherapy patients. Usually the PSA is going up as soon as the last dose is out of them. But then again, approximately a year after completing his first-line chemotherapy, again the PSA is soaring up. He's now got further radiological progression, still no bony metastases, but he's now symptomatic. The first time he's getting symptoms of his disease. He's got grossly lymphodematous legs, and he's got hydronephrosis and a wee touch of acute renal failure. Dr. Menemem.
If one can ever have a touch of renal failure, folks, then there you go. Dr. Jones, did the patient improve radiologically during the chemotherapy treatment? Can you remember?
He did. He responded very well. We did a trial, so we were scanning him regularly. In fact, he did respond.
Well, I think that's important because we can put that in context in terms of what we do next. He's obviously clinically now, as well as radiologically and biochemically progressing, so we've got to factor that in because I think that does influence with what we do. And in terms of the touch of renal failure, this is when we have to have these discussions about nephrostomies, don't we? It's not always the right thing to do, but I think it was what you did here.
We did nephrostomies
It's clearly the right thing to do. So we want to do the first thing we can to address his symptoms, and if that helps us to facilitate further treatment, so much the better. He's had about a year of biochemical control, and it sounds like he had symptomatic and radiological improvement with that, from what you're saying.
He wasn't symptomatic, so he had radiological and biochemical improvement and remained asymptomatic throughout.
Okay. Well, if that's the case, I think we can say he's got chemosensitive disease, and that's what I would want to know at this stage. But I think the difficulty is, what can we realistically offer him next? We know there aren't any standard options after taxanes, and really I think we're looking at trying some Mitoxantrone, but as Rob said, he's not symptomatic, or looking at clinical trials. And as Rob is an academic medical oncologist, I don't think there'll be any prizes for what happened next.
So in fact he went into the TROPIC trial, and you remember Lisa showed us the slide of the TROPIC trial, and this was the trial comparing Mitoxantrone with the new drug cabazitaxel in patients who'd had previous docetaxel. And again, he had a frankly stunning response to this. His leg swelling resolved after the first cycle of treatment. His PSAs have been crashing down, and the CT scan shows an impressive response to the lymph nodes. Obviously, we didn't know at the time the results of the TROPIC trial because he was in the TROPIC trial. But these, again, this is a slide Lisa showed you earlier, and cabazitaxel is a drug which is going to happen. So this drug shows a clear overall survival advantage for this group of patients. And cabazitaxel is in the process of being licensed in Europe, and it will be a marketed drug, I would imagine, in about 12 months' time. Whether we'll be able to get it on the NHS, I'm not sure. But look at the median overall survival advantage there, 2.4 months. It's exactly the same as Tax 327 in its first analysis in first-line treatment. So, you know, it's a clear advantage. The other thing I would just point out, though, there's a number of issues which we can't go on about. There we go. Except there's also advantages of the slides. So just do notice there's a little crossover at the beginning. Some patients are dying as a result of toxicity of this drug. That's going to be a real concern with this drug. I'm not trying to go into it in detail today, but I just raised that as something we need to sort out with this drug. And as I say, he had radiological and symptomatic and biochemical improvement, but he only had 3 cycles, and he was withdrawn from the cycle due to a protocol-mandated withdrawal due to toxicity. In his case, he had some manageable neutropenia, but he also had a derangement of his liver function, so he had to be withdrawn from the treatment. And you can see right now his PSA is going up fairly sharply as soon as he finishes that chemotherapy. So he's had 2 lines of chemotherapy, he's had 3 lines of hormone therapy, he's still here about 9 years after diagnosis. I'm going to call it a day, say this man's had more than conventional treatment. Now we just need to look after him, give him best supportive care, manage his renal function, manage his symptoms. Are we going to give him more docetaxel? Or is now the time to try Mitoxantrone? As Lisa said, it is active in this population, not licensed, but it's active, we can get it, it's cheap. Or are we going to now look at 4th-line hormone therapy? Your votes, please. So we're a 50-50 split between the quitters and the triumph of hope over experiencers. A few of you looking for hormone therapy, some of you interested in more docetaxel. Menemem.
Well, I think what we can say is this is chemotherapy benefits and chemotherapy toxicity, isn't it? And really you've got somebody who's responding well to chemotherapy and he's effectively being stopped because of, I think, what we would call paper-toxicity to a certain extent. He's not got any symptoms, but it would be risky, as Rob says, apart from anything else, to continue with chemotherapy in that setting. So I would think,
cabazitaxel.
yes, with cabazitaxel in that setting, I should say. So I think the options are, if it was possible to perhaps give him some more cabazitaxel, I cannot say that word, at a lower dose, or bearing in mind it's taxane-based, is there an option to give him some more taxane-based chemotherapy, which of course sometimes is a funding issue. You can't always persuade your NICE commissioners to fund these treatments because NICE only approve it really for first-line use, or we move on to Mitoxantrone. But I would certainly be thinking about chemotherapy in this particular patient.
I think the factors that I would take into consideration are not only the fact that he's benefited on 2 occasions, but importantly, he was still benefiting from docetaxel when he finished that, so there was no evidence of progression. If he was progressing before he'd finished, that would put me off. The fact that the PSA certainly remained down, the symptoms remained under control at the time he finished both chemotherapies, and that I think would encourage me for further chemotherapy. And indeed, that's what we did. We gave him 6 cycles of docetaxel. All of these treatments are given in combination with prednisone, essentially. And again, we see radiological response and symptoms again completely resolving. Every time we start this treatment is because his legs have swollen up again and his kidneys start getting into trouble. So again, further radiological response and his symptoms have resolved after 6 cycles of docetaxel. I actually gave it at full dose, but he was beginning to struggle by the end, and I stopped at 6 because he was really finding it quite hard going just in terms of fatigue rather than anything specific. Interestingly, the textbook would say that neuropathy is the cumulative toxicity of this drug. I don't find it a big problem in patients who have multiple cycles of docetaxel, but it's the fatigue which does seem to be cumulative for these patients. So here we are now, we're 10 years into his diagnosis, and his PSA is going up again. Now, 30% of you already quit 2 years ago, so and he's symptomatically progressing, but I'm not going to ask you actually here. So at this point I actually gave him Mitoxantrone because I was concerned that he wouldn't tolerate more docetaxel. Bit disappointing in terms of the biochemistry. No symptomatic improvement. Symptoms were stable like the PSA, but it didn't improve. Every time I've given him a taxane, within 1 cycle the legs have gone away. Not gone away, but come back. I'm not sure what to do here. He's had 4 cycles of Mitoxantrone. I'm not happy. He's not getting the symptomatic. He's quite symptomatic here. The PSA is in keeping with disease stabilisation, but we don't have a lot of alternatives.
Well, we don't,
What do you think?
So, is he tolerating the treatment? Is he getting any
water off a duck's back, Mitoxantrone, as it is for most guys actually. You either get bad toxicity or you get none at all. In my relatively limited experience with this drug.
And did anything happen radiologically?
Right, so this is where radiology is important, because at this point we re-scanned him, and indeed he had radiological disease progression. So the symptoms were stable, PSA was stable, but the disease was unequivocally getting worse. So at least that tells us we should quit the Mitoxantrone.
Which we need to know.
And so he had progressive disease. And so what can we do now?
Is he keen for more treatment, Dr.
He's desperate for more Taxotere, actually.
Is he?
He comes in and he says, why are you giving me this useless Mitoxantrone? I want Taxotere.
So did you give him more Taxotere?
Yes. Actually, this brings us up to the present day. He's still on pain. I gave him his 6th cycle. I gave him a reduced dose because of my concerns about tolerability during the last course of docetaxel. So I gave him 60 milligrams per metre squared. He's had his 6th cycle. I said we were only going to give you 6. I saw him on Tuesday for the 6th cycle, and he said, I'm coming back in 3 weeks' time with a full blood count, and you're going to continue. Okay? And he's tolerated it really well at the reduced dose, interestingly. And his symptoms have resolved, and we're actually going to rescan him at this point. We haven't, that's a bit of a lie, the radiological response. I'm sure it will be a radiological response. Because his symptoms have gone away, and the symptoms are very clearly directly related to the lymph node masses in his para-aortic nodes. His leg swelling's got better. So I was looking back at this note. This 13-year history actually looked right back. In fact, he first presented in 13 years ago, 1997. And he was at that point seen by the then child prodigy oncologist, one Dr. Rhona Menemem, back in the days when she knew what it really meant to be Scottish.
Well, I think clearly that is an important factor in this man's durable survival. But I think, just to recap on a couple of of points about that case. 13-year survival is very good, but I think here what's important is that we recognise, or Rob recognised, that this man had chemosensitive disease, and that's really the key. I mean, it's unusual with this duration and responsiveness to chemotherapy, but it was important to recognise that, and that did become the mainstay of his care, and I think that was quite likely. Now, as a clinical oncologist, the other thing I have to point out, of course, which Rob did allude to earlier, he did have radiotherapy earlier on in his disease. Now, this was not at a time when we were conventionally treating patients with external beam radiotherapy with locally advanced prostate cancer. So, of course, with my clinical oncology hat on, I think we have to claim some.
But that's not the subject of our talk today.
But there we go. Got to see that.
You've always got to put your oar in.
Got to see that.
So this is actually the summary chart of his progress to date. So although he has very chemosensitive disease, it's also worth remembering he has very hormone-sensitive disease. The other point is he first had docetaxel before it was licensed in the UK. I think he's going to get Abiraterone before he dies. So
you've given him unlicensed drugs, unfunded drugs. You're giving him almost all his chemo at the time was not licensed or funded, and therefore it's hard to translate this to the rest of the people in the audience who wouldn't have the same access to those drugs. So that's how you've managed it. But how have you managed to see it elsewhere?
I think that's a challenge, yes. But I am in no doubt that this patient has benefited and has a survival benefit from this course of treatment. For this individual patient, and I think I can't answer that question, it's a challenge. But there are changes afoot, and we'll come to those again towards the end, as to how these may play a role and how it may have to change the way we manage other patients earlier in their disease in order to make them suitable for these further treatments. But I think that is a very important point.
I think the other thing is it's pretty unusual. He never had bone mets, isn't it? You know, about 80% of patients get bone metastasis, so it's really quite an unusual disease. But
he's not a typical patient.
Not a typical.
But I chose him because he actually illustrates a number of points.
Okay.
Anyway,
so we'll move
back to
on
real life then.
Back to real life, folks. Now, this is a case of mine. This is one of my younger men who was referred in February of last year. 3 months of difficulty passing urine, 3 months of difficulty initiating flow. Was seen in the same month at the urology clinic, and he was also complaining of bone pain. Now, on examination, he had a large, hard, malignant filling prostate, suggestive of a locally advanced cancer. He had truss-guided biopsies performed, and these showed poorly differentiated disease, grossly abnormal prostatic architecture, and bilateral end Gleason 4+5 disease. So we went on to stage him, or rather the urologist went on to stage him, and he had a bone scan, which I'll show you later on that month, which showed multiple areas of increased uptake. He had an MRI scan that showed that the prostate cancer was invading into the bladder, so he had locally advanced disease, T4 disease. He also had substantial bilateral pelvic nodes, which were extending all the way up to the aortic bifurcation. And the MRI scan confirmed his multiple bone metastases. Now, he was keen at that time to go into one of our studies, the GenTax study, which I think we were doing in Glasgow as well, weren't we? Maybe not at that time. But it was essentially looking at the role of chemotherapy earlier on in the disease. But in fact, for that study, he needed to get repeat truss-guided biopsies, and it was the Easter holidays, and for neither love nor money or anything else I could offer, couldn't get anyone to do it. So he eventually just went on to hormone therapy. So you can see he didn't have a stunning response. I think that's probably a fair comment. His nadir PSA about 6 months later was 48.
And we do know that if you get your PSA below 5, that's a good prognosticator in the patients with presenting with metastatic disease.
It is indeed. So there's his staging bone scan, folks. You can see he's got uptake in his scapula, he's got uptake in the right side of his pelvis, little bits of disease in his thoracic spine, a bit of osteoarthritis in his knees and his hands, but he's got some bone mets, So how did he get on? Well, I have to say not brilliantly. The first thing that happened was he was complaining of some hip pain, which, as we all know, happens. And he was seen by a relatively junior member of the team who arranged for him to have some palliative radiotherapy. And I think this is a learning point, because you've seen that from the bone scan he had some disease in his femur. And I think always in these weight-bearing bones we should get some plain films and think about orthopaedic stabilisation first, because unfortunately that's exactly what happened. He had a pathological fracture exactly a week later and had to have a gamma nail at that point. So we started him on some Castrate, I think towards the end of late February, because by that time his PSA was 96. But after the fracture, we'd already arranged for him to have a restaging CT scan because we realised things were clearly not going that well. Although at that time when the chemotherapy word was mentioned, he seemed to have somewhat gone off the idea. But he had a CT scan and that showed quite extensive infiltration by sclerotic and lytic metastasis. And he also had large retroperitoneal nodes which were about 2.5 centimetres. During that time, we gave him a single exposure to his right shoulder because he was getting some shoulder pain. He had another bone scan, and as you can see, it's a lot worse. But I think it's also useful to talk about bone scans because often when we repeat bone scans and patients getting systemic treatment, they're very difficult to assess. You know, sclerotic changes can happen in response to treatment, and it's one of the reasons why chemotherapy trials in prostate cancer were so difficult for a long time, because all you were measuring was bone disease. This is different, this is quite clear cut. He's obviously got new lesions, they're more intense, they're in different places. So, he had a good response to his palliative treatment, and as Dr. Jones is about to point out to me, any delusions I had that his PSA was stabilising a couple of months later from about 96 to 115 were soon removed from me because his PSA by the end of May was 226. So at that time we decided we really needed to work him up for his chemotherapy. So he came to the chemotherapy unit a few weeks later, and by this time he actually had a scalp metastasis. So again, that indicates the pace of the disease really was beginning to kick off. GP had removed that, but the other problem was, as you can see, not only had his PSA risen quite considerably, he also had quite significant myelosuppression. So what am I going to do now, Dr. Jones?
Well, the first question is actually back to you. Well, actually, this is a summary of the case so far. Keep it in line with the others. So here we have a young man. How old is he? Late 50s, mid 50s?
53.
53. It's early 50s when you're going in that direction. And you can see that he's really had a pretty disappointing response to castration therapy. Okay, both symptomatically, radiologically, and biochemically. He then did get bicalutamide with maybe without much surprise, without much benefit from that. And he's also been receiving zoledronate within its licensed indication for metastatic bone disease. So Dr. Menemem, here's a picture quiz for you. What is that a picture of?
I think that's one of your holiday snaps, Dr. Jones.
It's a boat. What is the boat doing?
It is indeed a fine seafaring vessel, which might just be leaving the harbour, but might not.
Incorrect, it has already left. So, again, I think this to me is a patient who is not really benefiting from hormones. And we knew that from pretty early on. He's a young man, again, he's become hormone refractory early on. This man is going to get chemotherapy at some point for his disease, and he's not likely to respond. He wasn't likely to respond to bicalutamide. But by the time you get around to it, the platelet count's already falling, and you've missed the boat for chemotherapy.
Well, I do.
That's my view. And I would have actually given him the chemotherapy instead of the bicalutamide. I stand out on a bit of a limb doing that, but in some patients, particularly patients who do not really benefit from castration therapy, I would have strongly encouraged him to have the chemotherapy at that point when he was still fit for it.
I think that's a fair point, but the patient certainly at that time wasn't keen and had symptomatic bone metastasis, so that was why we proceeded the way we did.
What would I do right now, given
what would you do
that you've now referred him to me? I would still want to give this man chemotherapy, actually. Platelet count, though, obviously is of concern. We wouldn't normally give 75 milligrams of meter squared of docetaxel to a man with a platelet count of 72. 72, I would be tempted to give a 3-weekly dose, but I'd probably start off with 60. But I think I'd probably actually go for weekly chemotherapy now with docetaxel. This is off license, it's certainly not approved by NICE, and it didn't show any survival advantage compared with Mitoxantrone and TAX 327. But this man would never have been permitted into TAX 327 because he had got a platelet count of 72. So TAX 327 is not about patients like this. And I would actually, to satisfy Dr. Kirkbride, I would put in an extra formulary request on the basis of exceptionality, that this man is exceptionally likely to die if I don't give him chemotherapy very soon, and that I just might be able to turn that shit round and get it to come back tomorrow?
Well, that's exactly what we did. We gave him some weekly docetaxel, and his PSA started levelling off, and it's now about 200. And he's maintained his blood count, and he's still on chemotherapy, and he's clinically and biochemically responding. So I think this was a useful case to illustrate those points. It's still about 50. So, but I think mild suppression is something we do have to deal with, and it's just useful to illustrate you can still treat patients usefully with chemotherapy even when one is challenged by blood counts.
If his platelet count goes back up, which it probably will, hopefully, he's benefiting, are you going to convert him to 3 weekly?
Absolutely. Absolutely, because I think there's very good evidence to do that.
Yeah, that's what I would do.
Yeah, I think so. Jolly good.
So you're getting, that is, the boat's back in the
The
harbour.
boat is back in the harbour, folks. I don't think everybody left. Right, over to you again.
Okay, next case, similarly aged, 58-year-old man of diagnosis. He's histologically proven, multiple bone metastases at diagnosis. He's very fit. This man is very interested in drugs. In fact, he's a professor of medicinal chemistry. He spent his entire life researching new cancer drugs. And he's referred to me. So, and at this point, he's actually a year into treatment. He's not unlike the previous case. He's a year into primary castration therapy, young man with bony metastases, and at this point his PSA is going up and he's moderately symptomatic. He's got controllable symptoms, predominantly in the right hip, as I recall. And at this point I put him into a phase 2 trial. Again, this is before we had access to docetaxel routinely. This is actually a phase 2 trial comparing docetaxel with or without a novel drug, and he drew the control arm, so he got docetaxel prednisolone. And he's now attending my clinic for cycle 4. And these are the PSA results that I have in front of me. His symptoms are stable, they're no better, but they're stable. And he's tolerating the treatment reasonably well, although he did have to have a dose reduction due to an asymptomatic prolonged neutropenia in cycle 1, which he probably wouldn't have spotted if he hadn't been in a clinical trial, in fairness. But his PSA here, it's certainly not going up the same way that it was before he started, but it's not really coming down. It's maybe on the upward side of a level trend. And so what are we going to do? In fact, what are you going to do? This is an entirely typical situation, I believe. Are you going to stop the docetaxel and consider alternatives? It's not responding symptomatically, not really responding biochemically. Are you going to continue docetaxel as planned, press on regardless, putting him at risk from future toxicity? Or are you going to re-escalate the dose of docetaxel, remembering I had to cut the dose after cycle 1? No, I couldn't think of an option D, apart from go to the bar. I knew you would choose that. Okay, so half of you are going to stop, and the rest of you are split between continuing at a higher dose. So in fact, I guess let's tell this a fair way, 3/4 of you are going to continue docetaxel. Okay, there's some people who re-escalate the dose. That's interesting. So we just continued at the same dose, actually, and he actually continued to 7 cycles before stopping due to tolerability issues. And of course his PSA now actually does come down. And his symptoms do start to improve. And maybe more interestingly, the PSA and the symptoms, so the symptomatic response and the PSA response actually persists for some time after discontinuing docetaxel. Remembering this man was castrate refractory after 10 months, he's now 2 years down the line. And I think really chose this case largely to illustrate the point that, again, particularly with chemotherapy, you should not move too quickly on the basis of biochemical or lack of biochemical response. But I'm glad you all seem to understand this. The general mantra is that you shouldn't really look at the PSA until they've had at least 4 cycles of treatment. And I think I would go with that, unless there was overwhelming symptomatic or radiological response, progression rather. And even then I'll be very cautious on the basis of bone scans. But anyway, shortly after this point, as PSA starts to go up again. Note that I hadn't given him bicalutamide prior to his chemotherapy because he'd had this relatively short duration of response to first-line hormone therapy. But I decided at this point, seeing as he had actually technically exhausted all conventional therapies, or licensed therapies at least, I did decide that now was the time to give him bicalutamide, because that was the one option he hadn't exhausted. And as I predicted, it really made no difference to his PSA. His symptoms had really just grumbled on throughout this time. But again, so after 2.5 years, PSA is going up sharply again. And at this point, in fact, I'd actually referred him back to a colleague who we discussed it. We decided to give him docetaxel again. Remember, he had this funny little sort of plateau with a tiny little rise on it before responding to docetaxel, and then again a further fairly sustained biochemical response to re-challenge docetaxel. He had 6 cycles on this occasion. But then now we're 3 years down the line, PSA is going up, symptoms are getting worse, and his bone scan is getting worse. He's had chemotherapy twice, he's had 2 lines of hormone therapy. So what are we going to do next? So again, I think we've exhausted all licensed therapies for this man. Are we now going to say, pack up our bags for a man who was failing after a year, you've got 3 years out of it, we're now moving to best supportive care, maybe a shot of radiotherapy to that dodgy hip. Docetaxel, third lot of docetaxel. Mitoxantrone maybe, not licensed, but there is evidence of activity. Or we're going to go for third-line hormone therapy, bearing in mind he didn't really do very well with first or second line. Votes, please. Come on, didn't see anybody leave the room, there's still 6 of you left. Okay, so what are you going to do? I wish I'd had you guys here when I was trying to make a decision myself, actually. Okay, that's interesting. Mitoxantrone, 43%. Some of you want to give him a third on a dose of Taxol. Get that at the back. Third-line hormone therapy. Yeah, I think any of these options are possibles. You could argue that none of the active treatments are permissible. So in fact, I reached for the last desperate gasp of a medical oncologist, and we put him into a phase 1 trial. He said he was interested in drugs. Okay? He was lucky because that phase 1 trial was actually Abiraterone. And it's interesting because he did get a relatively brief biochemical and symptomatic response to Abiraterone, remembering he really hadn't responded much to other hormone therapies. So it was a drug with some activity, but not stunning activity for this patient. But he stayed on it for 10 months, actually. But at this point, he was now progressing symptomatically. And so he did at this point have, for the first time in his life, some palliative radiotherapy. But look, we're nearly 4 years into his treatment with metastatic disease. And this is just a reminder, this is the same data that Lisa showed you about Abiraterone, and this is a drug, I think what Lisa didn't tell you, and we are permitted to tell you, is that in fact the post-chemotherapy trial has been unblinded. I've been told which of my patients, not the trial this patient was on, this patient was on the phase 1 trial, the phase 3 trial. We now know which ones are on the placebo, and we've been recommended to switch those patients to the active drug. That is in the public domain, so you can draw your own conclusions. But in fact, we put him into the TROPIC trial at this point, okay? And he drew mitoxantrone, which remember was the control arm. So in fact, by the flick of the medical oncologist's coin, he got what most of you wanted to give him anyway. And he did really well with it, in fact. It was water off a duck's back, no problems at all. And PSA sort of gently drifted down, his symptoms have remained stable, radiologically he's remained stable, again we're scanning him relentlessly because he was in a trial. So he had the full 10 cycles of mitoxantrone and did very well with it. And we're now at a situation where we're, I guess we're 4.5 years down the line. This is the sort of summary of the case. So note that he actually, he actually survived to 5 years, he died earlier this year. But he had his first chemo a year after starting treatment for metastatic castrate-refractory prostate cancer. I don't think this is a patient who is obviously an exquisite beneficiary from any drugs, But nonetheless, we've given him several lines of chemotherapy. My problem with this patient is that I'm just not sure whether all this chemotherapy made any difference to him.
I have to say that was my feeling when I looked at this case, but I think he was the ideal patient for this sort of approach. You know, he was an academic, he was interested in drugs, he was clearly
I'm an
good
academic.
trials. If you say he was interested in drugs, I have to say that might mean something very different, but there you go. But I think the PSAs here, as on the slide, are quite unusual. They're quite hard to interpret, and I don't think it's as clear-cut as the first case that Rob showed, where there was very obvious chemotherapy benefit. And it is harder. Do you know, I think it's harder to be confident about chemotherapy working when it was starting so early. I have to say these were my thoughts for this case.
But to some extent, do not have to go with the force. We know that tax 327 was positive. He would have been permitted into there. It wasn't sort of patient-tailored treatment for half of those patients. Half of them can't have had symptomatic response because they didn't have symptoms when they started. Do not have to take the data at face value and offer patients like this the chemotherapy. I think you could make the same, you could make very valid points about the second, third and fourth line chemotherapy. And again, that was mostly delivered within trials.
I think this was the right approach for this man, certainly. I think that was very much the case. So
I did give him a third challenge of Taxotere before he died, just to reassure you.
Just to show
actually, because his platelet count, he went to develop bone marrow failure, and again, he was begging for more drugs. And I gave him a weekly dose of tax, and it didn't make any difference in this situation, which didn't really surprise me. So I think that's maybe a more typical case, and I'm not sure.
Me again. He had steroids with his chemo? Yeah.
Yes.
Did he have steroids not with his chemo?
He did. We gave him low-dose dexamethasone, and towards the end, in fairness. And the bone marrow failure developed within a couple of months of starting the low-dose dexamethasone. He had no response to that.
That was just, yeah, because you could argue what you saw there was successful responses to steroids.
Yes, and of course all of the chenos, including the Abiraterone. In fact, the Abiraterone was not given with steroids at this point because it was before we knew we had to give steroids with Abiraterone. I think it's an interesting question we'll have to ask if we start using Abiraterone as to whether Abiraterone sort of moves the role for steroids, because it probably works by a similar mechanism, that is suppression of adrenal androgen biosynthesis. And also the other point to draw is that there are certain differences between the steroids in anecdotal experience, including my own. Just because a patient progressed on prednisolone doesn't mean that they may not benefit from dexamethasone, and there's no literature to support that. But I think anecdote would support that. I don't know whether you'd share that view.
yeah, I think that's reasonable.
So we thought we do have one more very short case which we'll come to at the end, but we thought it would be useful to take stock at this point, because I think now is a time of unprecedented change in the management of metastatic castrate-refractory prostate cancer. We've gone from having really no proven benefit, no treatments with proven survival advantage up to 2004, to having androgen receptor antagonists like glutamide, which add a little bit, docetaxel, which adds a little bit more. But we've now got these three other things coming through. We've got cabazitaxel, unequivocal overall survival advantage in the TROPIC trial. That's going to be licensed. It may or may not be available to patients, and as I said earlier, there are a number of issues with cabazitaxel, but it is going to be an option for these patients. We've got new hormone therapies. We've talked a lot about Abiraterone, and that is going to happen. We don't know the results of the trial, but I think we'd all be devastated if Abiraterone doesn't make it as a marketed drug. Again, whether we'll have access to it at the NHS, we don't know how much it's going to cost, etc. There are all those uncertainties. There's MDV 3100, which Lisa referred to, which is another new hormone treatment. There's another drug which works in a similar way to Abiraterone called TAX 700 coming through quite quickly. So there's a number of new hormone therapies which, at the very worst, are very well tolerated. So the balance between side effects and benefits is almost certainly going to be weighed in favour of benefits. And we've got these immunotherapies such as Provenge, Cyclus-LT, again, which Lisa referred to, and there are a number of other things coming through which may or may not show advantage. Provenge is some way of being available for love or money in the UK. It's currently only available in the trials in the US, but it is approved in the US now. And I think we're actually going to have to redress how we treat these patients if we're going to be able to now, rather than simply asking when do we give them the docetaxel, actually the question is not just when do we give them the docetaxel, but when do we then give them the Abiraterone, when do we then give them the cabazitaxel. And so this is going to provide a number of challenges in the future. And we can look at metastatic castrate refractory prostate cancer is in a number of phases. So the green phase is the phase where they're asymptomatic and they've got a rising PSA. The yellow phase is where they've got controlled symptoms, so there's a bit of radiotherapy here, a bit of radiotherapy there, or a bit of simple analgesia maybe. And then you've got the orange phase, which is where the symptoms are now poorly controlled, which at the beginning was when most of you wanted to give the chemotherapy, remember? And then you've got a purple period of life-threatening complications, such as bone marrow failure or spinal cord compression. This is the period of the missed boat, in my view, and obviously this fairly rapidly precedes death. What have I done wrong? Oops, previous ago. So once you progress from the orange block to the purple block, I think you've missed the opportunity to give chemotherapy. You may be able to clutch the boat back into harbour with your siren-like qualities. And of course, if you leave starting the chemotherapy until the orange phase, remembering that chemotherapy takes longer than to give than the overall survival advantage it imparts, you actually have a relatively narrow window of opportunity then to consider second-line treatments. So you probably aren't leaving enough window of opportunity to give these patients cabazitaxel, for example. And so actually delaying your chemotherapy until they reach that orange phase, you may not have missed the boat for docetaxel, but I am concerned that you may subsequently miss the connecting boat of cabazitaxel or abiraterone or whatever it may be. And so I think we probably do need to consider whether we should be actually moving these treatments forwards. I think there's a clear group of patients where you can say this patient's never going to want chemotherapy or never going to be suitable for chemotherapy, in which case clearly you're not going to give them chemotherapy now. But I think there is nonetheless is also a clear group of patients where chemotherapy is going to be an option at some point, and that actually we maybe need to think about whether we should actually be getting on with it a bit sooner than maybe most of us do. And by doing this, by giving the chemotherapy earlier, you see, we can widen this window of opportunity for subsequent treatments. That was a spare slide, which I don't think we need to discuss. We'll move on to, I don't know if you want to comment on those
No, I
philosophical
think we might
points.
perhaps suggest some of these points in discussion, but I'm going to do one final case. I think we need some interaction again after our very informed lecture by Rob there, but this is a very different clinical problem, but I thought I'd just throw this in and see what you all think. This is another one of my young men who was previously very fit and well and presented to his GP acutely with lumbar back pain and got admitted. He had an MRI in the community, in fact, that suggested he had some instability of his spine. So when he was admitted, he was found to have a PSA of over 700, and the urologist reviewed him as an inpatient. He again had a locally advanced prostate cancer, and he had established bone metastases. Now, they went straight ahead and they put him on his LH-RH analogue. They did discuss the Stampede trial with them, but he declined, and he didn't in fact have histological confirmation of his disease, which just useful to mention in the context that the Stampede trial actually allows patients to go in if they've got a PSA of over 100, if they've got known bone mets, and they don't have any histology. So whether that's a point for further discussion, I actually throw that out there. But again, less than stunning response to hormones, I think it's fair to say. His PSA a few months later was 18. We put him on some Castrate, but we're thinking very much about moving on to chemotherapy, and we did do this relatively promptly after he was started on some biphosphonates. But the problem was he had a serious allergic reaction to his taxane-based therapy, which was very much a problem in the early days of the taxane drugs, which I'm old enough to sadly remember. So this was very difficult, and we really had a very difficult problem here, and I really didn't know what
what
to
the
do.
nature of the reaction was, what actually happened.
It was an anaphylactic type reaction. It was facial swelling, difficulty breathing, widespread urticarial rash, really quite scary stuff. So
Blood pressure.
blood pressure was okay. Blood pressure was okay, but it wasn't good, and the girls at the chemotherapy day unit were not happy, and I wasn't happy. So what do you think, folks? What do you think the options are here? Should we try again? Is there any sense in trying again, bearing in mind that's what happened? Should we look at something different in terms of his chemotherapy? He is symptomatic, but Mitoxantrone doesn't confer any survival benefit. Should we switch him to some hormones? Should we just put him on steroids? And I'm afraid I was rather dwelling on the fifth option, but I'm hoping you might choose one of the other four and give us some recommendations.
Getting some advice out there for help, actually, as well.
Yes,
So,
absolutely.
help was at hand, I would have called for it, I must be honest.
Well, you very much share the view of my nursing colleagues in the chemotherapy day unit, because they were not happy about me re-challenging this patient. But the patient was desperate to have another go. So we talked about it fully. I conferred with a couple of colleagues who didn't think I was completely insane for doing it. And this is what we did. And it was very much a cobbled together sort of regime. But the pharmacist suggested adding in an H2 blocker, which is what you give pre-Taxol. I cranked up the dexamethasone and started it a day or two earlier. We doubled the time of administration of the drug. I gave him enough antihistamine to stun a horse, quite frankly. I think by the end of that I could have done with a sedative effect, and we kept our fingers crossed, and it all went uneventfully. And he's been absolutely fine ever since. And I think that the nice story about this man was, after his first cycle, his PSA halved. And he told me he was down in London on a day with his family, and in fact he came out at Covent Garden Underground where we came out of earlier on, and you know it's very steep there, and the lifts had broken and they had to climb the stairs, and he said he would never have managed to climb the stairs before he'd had his chemotherapy treatment. And it's just nice, apart from that other problem, to remind ourselves that patients often get very quick symptomatic benefit from chemotherapy, and it's often something I find myself telling patients when they're a bit anxious about whether or not they should go ahead.
Did you continue with the other supportive measures through the rest of his
I've been too scared not to, quite frankly, but the steroids are becoming a bit of an issue because it's a big dose, so we're going to look into maybe tailing them off a little bit and seeing how we get on.
So,
question.
final question of the day. Think very carefully. So this is a mark of our success. Have we entertained you enough?
We're reducing
I
ourselves.
can't actually remember what the figures. There's that. All the people voted. Nobody's left. Nobody's left.
Come back from the bar.
Thank you very much. I've never seen anyone rig the voting system before. Thank you very much, Robert. That's very good. Any questions on those presentations? Seems like everyone in Glasgow gets Taxotere and quite a lot of it. Questions? Peter Kirkbride's gone. Yes.
Just answer to my Jane Capra, your oncology from the West. Do you think that they will ever do any trials in this country with immunotherapy, bearing in mind how expensive it is?
Well, I'm about to open one next week, actually. Not with Ciculusa. I think the question about is, if there's a question specific about Provenge, then I don't know. I mean, I guess the question is whether or not they'll, first of all, will they set up a manufacturing facility? At the moment, my understanding is the manufacturing facility for that ex vivo stimulation is only in the US. I assume that they are setting one up somewhere in Europe. I don't know enough about the technicalities of it. It doesn't have to be next door. You can ship it.
It's in the same town.
Yeah. It does have to be in the same town,
yeah.
Is it? Right. So I would imagine that's going to be a big challenge. And I guess the question is whether they'll even have the guts to put together a health technology assessment, a nice application. And I'm afraid I don't know. Does anybody in the audience know whether there is a nice submission going ahead for Provenge?
Not that I'm aware of at the moment, but it will be the same as anything else, won't it? When chemotherapy came along, everyone went, right.
Yeah.
And then it's patient-driven. And we've seen the evidence that's there. Questions will be asked.
I guess there's the extra investment from the company to set up the facility on the risk that they may never get enough users to make it cost-effective for them. And I'm not sure. But as I say, so not all immunotherapy is about CYP-LuCell-T. And as I say, there are a number of other drugs that are now looking at this, which don't involve this extracorporeal stimulation. So there are specifically a number of drugs coming along looking at drugs which non-specifically stimulate the immune system. So there's a drug called ipilimumab, which has recently shown a fairly amazing survival advantage in advanced melanoma, where nothing has ever really succeeded before. And this is currently in trials in post-chemotherapy patients with prostate cancer. As I say, is about to start the trial in a pre-chemotherapy window. That's the only one I'm aware of that's up and coming in the UK at the moment. There have been a couple of notable failures of vaccine-based trials recently, which have involved the UK. So I'm ill-informed about Provenge, but I think if something simpler comes along with a similar kind of advantage, and there's by no means any certainty that it will, then that may be more realistic. What Provenge has done is it has proven the paradigm that immunotherapy can work in prostate cancer, and I think that will drive the change.
It still took its time to get approval, didn't it? Because there was the first study, it was still rejected after the first study.
I think because the results were unbelievably good.
Right, well, thank you very much for that great double act.